So TB and AIDS are common in immunocompromised patients. And of course, you can get TB and being healthy as well, but highest risk are those who are immunocompromised. It's a very old disease. If you watch any Western and someone coughs up blood into a tissue, that's because they have TB, right? So why aren't you guys wearing N95s? You guys are at risk, right? Right, you have negative pressure right now. So it was called consumption back then, all right? So you have consumption or TB, all right? So it's very, very common, much more common than you think it is worldwide, right? It's not as common in the U.S., but it's very, very common in third world countries. Obviously, those that are huddled together can be a higher risk because you're sharing it within a 6 feet radius, right? So what else we got here? All right, so TB overview. So it's life-threatening. All right, you have to get you have to be on therapy if you get TB. It doesn't develop what's called latent TB. You can get TB right away, but usually it comes back in a while. Right, it could be 6 months, it could be a year. It comes back usually when you're in the hospital setting or when you have a insult to your body. Then TB then proliferates and it becomes active at that point. We'll talk about the difference between latent and active TB. But basically TB takes hold and it forms little what are called granulomas inside your chest. And it's an aerobic bacteria, so it sits up at the top of the apices where you have more oxygen, right? So it's life-threatening, affects 1/3 of the world population, right? So the way we can get rid of TB is by being adherent to the TB meds. We'll talk about the TB meds on the last TB slide here. All right, so non-U.S. citizens, immigrants, they're high risk for TB. All right, low socioeconomic status usually are more huddled than others. Ethnic minorities, unfortunately, are also of the other two varieties up top there. And we have HIV/AIDS are high risk as well because they're now immunocompromised, and now the TB can take hold easily. All right, and we'll talk about HIV/AIDS as well. And TB is one of the #1 killers of HIV/AIDS patients. All right, 11 million HIV positive patients have TB, which is 1/3 of them, approximately. So how does it happen? It's transmitted by airborne. It's super, super tiny, so regular mask is not going to do it. And N95 mask, the fibers in N95 mask is not going to block TB either. So the way N95 masks work is they are electrostatically charged. So when the little molecule comes by, it, like magnet, just goes up against the fiber. It's like back in the middle of COVID, they had us like baking them at 150 for 24 hours, and then we were reusing our N95s over and over. It's like it's not going to work. You're destroying the electromagnetism of the mask. So if you're not wearing an N95 mask, you're at risk of TB. It's usually 10 minutes of exposure within 6 feet. That's usually going to do it to get exposed for TB. About 3,000 droplets in one cough is going to get you. Is going to be out there, right? And it's going to not just like go and just sit on the ground. It's not going to go 6 feet and like that. Like coronavirus, it just falls on the ground, right? If you're 6 feet away. But this gets aerosolized. It's super, super tiny droplets. The size is somewhere on there, I'm sure, like something microns, but it's going to then just stay in the air. So if you're like in someone's house and they're coughing and they get a tissue and it's like, oh, they get a cowboy hat all of a sudden, and they're like, where'd that vest come from, right? So that's going to be, they're going to have TB, right? Or you're going to have TB too. So what else? So transmitted by airborne precautions. So we need to do airborne isolation for TB patients. So that's all the things we talked about before, plus we're going to add on a special mask, an N95, right? N95 or a respirator, a PAPR, right? So if the patient's moving, or they should be wearing a mask, like if they're mobilizing, they're not going to wear an N95 mask. It could be fitted for an N95 mask, right? You're not going to tell the patient to bend over and, do you smell the saccharin? All right, that's not going to be a thing. They're probably going to be dyspneic. Either way, that's the airborne isolation strategies for TB, okay? And it walls itself off inside the lungs until you have a stressor in your life, whether you get hospitalized or the like. Then that's the time that it's going to eject into the bloodstream or eject into the lungs and cause you to be infected with TB. It's called an active TB infection. All right, so we have acute TB. That's like where you get exposed at your friend's house who's a cowboy, and then a week later you got TB. That's very uncommon unless you yourself have HIV. You should get HIV tested at that point. But that's going to be a reason why you get TB immediately. Most commonly is like what we described as latent TB. That's where you have TB in your lungs, and then it looks for the right time to become infectious. That's usually, it takes a long time for that to happen, right? That's usually with an intact immune system because your WBCs don't know how to fight it. So it says, you know what, I don't know how to fight it, so I'm just going to build a wall around it. And it builds a little wall around it, and it kind of loculates it away. Okay. What else? So yeah, when TB resurfaces, then it's called active TB. Okay. So it can be confusing, like which one's active. Well, there's active TB at the beginning, which is called primary active TB, and then there's TB when you actually have the symptoms of TB. And what are the symptoms of TB? These are classic. Just think of your cowboy, right? So they have their coughing up blood. What's that called when you're coughing up blood? Hemoptysis, right? They have a cough all the time, right there with little baby hands, right? It's got a little cough. It's hemoptysis as well. They have night sweats. That's very, very characteristic of TB. And they got weight loss and anorexia. What is anorexia? They don't want to eat, right? So they get weight loss as well. Okay, so that's classic. And of course, they have the SIRS symptoms. They got a fever. They got what else? Other symptoms? They got SNS, tachycardia, or tachypnea, and then white count, right? And which ones can be low or high? White blood cells or temperature, right? All right, it's a diagnostic test. They can do a chest X-ray to see, well, there's the cavitary lesion on their X-ray, right? So it looks like it's literally a walled-off lesion, as you can see on the X-ray there in the middle, right? And then another way you can find out someone has TB is we do sputum cultures, right? Not just a regular sputum culture like you do with anything else, like pneumonia. You do it for TB pneumonia. And it's a specific test. It's called the acid-fast sputum culture, right? So you're looking to see if their sputum is growing these bacilli, right? And it's just 8 hours apart. Usually they wait. It's like, oh, we can do it, let's do it tomorrow, and let's do it the next day. And then it's tomorrow. I was like, did you do the sputum culture this morning? Oh, no, I forgot. Let's do it tomorrow. Then you're on airborne isolation for like 5 days. You could get it done within 24 hours if you rule out TB with the acid-fast stain, okay? And then blood, we can do a blood test to see if the TB is there or not. And that's going to be the gold standard, really, is the quantiferon test. And that's going to look to see if their TB is present or not. But we still have to do this hokey test here that was developed in 1845, which is the Mantoux TB test, where you put a little attenuated TB, which is like weakened TB, into the skin, and then you see if you form an immune response or not, right? If you form an immune response that's significant, that means you have TB, right? And it depends. If you can't really form a good immune response if you have HIV, for instance, or immunocompromised, right? So we change it from 5 to 10 to 15 millimeters, right? So usually more than 10 is a regular person, whereas more than 5 is someone who's immunocompromised, right? Like HIV positive there. All they need is 5 or greater, and they might have TB. And they have to get the quantiferon gold test anyways. So it's just, we might as well just do that guy, the quantiferon. Okay, so what else? The complications of TB. Not only can it cause TB pneumonia, but it can go into the bloodstream, like I mentioned, and cause sepsis, but also it can deposit in other places. And just like the British military or the Roman Empire, it goes everywhere, right? So it's called miliary TB. So it can go to their adrenal glands. It can go to everywhere through the body. And then now you have more problems on your hands. All right, so the treatment for TB. So treatment is to cure the TB, to get rid of it, and we're going to hit a bunch of combo drugs. The nice thing is it's just 4 drugs, and you're going to mix and match them. We have like latent TB, where you have TB for a long-standing period of time, or the TB was not like acute right now, and that's where we have 4 options: a 3-month option, a 4-month option, a 6-month or 9-month option. You sound like a car salesman. All right, you're going to do, basically everybody's getting isoniazid, which is INH for short. So isoniazid is going to be given, and they can just do that for 6 months, right? What is it? Or 6 to 9 months. They can just go 1 drug for 6 to 9 months. Or they can be done in 3 months, and they can combine isoniazid with rifampin, right? It's actually, rifampicin. All right, so, because rifaximin is similar. Rifaximin is for liver patients. Rifampin is for TB patients, right? So we can combine rifampin and isoniazid, and now you're going to shorten the time. Whereas, like, you know what? Let me just do the other drug. Let's just do rifampin for 4 months. You could do that too, Okay, we can get done in 3 months by either taking a weekly shot or an everyday shot, or an everyday, not shot, but an everyday pill or a weekly pill. It's like, what are you going to opt for, right? You're going to probably opt for the weekly pill. But guess what? You now have a Zoom meeting in your future, right? Every Saturday morning, they got to do direct observation therapy. They got to make sure you take it, right? It's a public health concern to not spread TB. So they're going to do DOT therapy or DOT therapy, direct observation therapy, to make sure that it gets given, right? It can't be the direct observation of a family member. It's like, oh yeah, Tia took it, I promise, right? It's not. It has to be directly observed by, by a public health person or a health nurse or something to that effect. If someone has active TB, they're really going at it, they're really coughing, they got hemoptysis, they got the fever, the night sweats, the anorexia, then we're going to hit them up with 6 months of therapy, right? You can't get out of it. The other one, you had like a positive PPD, and you had a positive IGRA or quantiferon. Then we could do latent TB regimen. But with the active TB, you're actively have hemoptysis and such, then you need to get a 6 months of therapy, and we're going to add on 2 more medications. So before, you can still have the OGs, the INH and the rifampin. Those still are going to be there, but we're going to add on some other deals. Here we're adding on pyrazinamide and ethambutol. Okay, so this is called RIPE therapy. Rifampin, isoniazid, and then the pyrazinamide and ethambutol. Those guys are for active TB. Okay, so you do all 4 of them for 2 months, and then for the remaining 4 months, because it's 6 months of therapy, the remaining 4 months you hang on for, you do with the INH and the rifampin. Now you're going to have to also add a 3rd pill in there, and that is B6, right? Pyridoxine B6. So B6 needs to be given with isoniazid. Otherwise, you get peripheral neuropathy. You're going to get neuropathy and neuritis, which is not good, right? And there's all kinds of mnemonics out there. These are all liver toxic, right? And also they're going to be, they have unique symptoms for each. And it's nice because INH has iron accumulation. I can't read it now. It has neuritis, is an N, right? Iron accumulation is not so common, but definitely hepatitis because it is liver toxic, right? And then we also have some, we got ethambutol or ethambutol that affects the E's or the I's, right? For E for eyes, right? Turns things red, green as well. Pyrazinamide causes hyperuric acid. And we'll talk about uric acid when we talk about musculoskeletal. So that's going to come into play when we talk about gout. When you would have to be worried when someone had gout. Okay? And then R for rifampin turns things red-orange. So that's kind of the nice thing about these guys. They all kind of fall into place as far as the mnemonics, and it's not a stretch for the mnemonics. All right, our last section is HIV and AIDS. All right, so HIV had a lot of that's, I guess, superstition, I guess you would say as well, but a lot of hysteria in the 80s when it came out. Right, there's a lot of consideration about what caused it, what didn't cause it. And, it is very serious. It takes about 10 to 12 years to get AIDS. It takes a while for it to hit. But when it does, it depletes and decimates your helper T cells. And we'll talk about how the helper T cells work. But here's an example of the hysteria.
When AIDS first emerged, the media was accused of adding to the hysteria.
AIDS is the new disease sweeping across America. Not scared yet? Maybe this graph will change your mind.
Fear of AIDS was so strong, a stigma grew about touching those with the disease.
Alex, what can we do about this stigma?
It's important to show solidarity, which is why I'm currently holding hands with an AIDS sufferer.
You're holding hands with them right now. Can we see them?
No, they're in a wheelchair, so they're just out of shot.
Well, why don't we just zoom out? Director, can you just zoom out?
Well, I don't think that's necessary. He's just gone. He's rolled off. We're on a hill. We're on a way.
Scientists struggled to keep the population calm.
So everyone in your lab is calm?
The results are nothing to panic about. That's not someone working on AIDS.
However, the media seemed to care less when they realized it was largely spreading amongst certain groups.
It mainly seemed to affect male homosexuals.
Oh, so we don't need to worry.
Well, gay people still deserve
Change of plan. Our top story tonight is no longer the AIDS story, as a dog in New Hampshire looks like John Travolta.
Is this really happening?
Yeah, we got a picture right there.
So yeah, there was a lot of hysteria. Of course, that's satire, but there was a lot of this on the news. A lot of it no one would touch anybody. It was a whole thing in the 80s. All right, but yeah. All right, so your helper T cells are integral to your immune system. They are helper T cells. They are going to release all kinds of chemicals. Like we talked at the beginning with sepsis, there's all kinds of chemicals, chemotaxins, interleukins, cytokines, etc. They release all kinds of things to promote the immune response. It's like the center, like almost like the CIA. It's going to not mitigate, but it's going to coordinate the whole attack. It's going to attract more troops. It's going to attract more white blood cells that are going to bring things to them to present, to develop antibodies against. It's very, very integral. And we've talked about how the immune system works briefly. We talked about hepatitis B. But yeah, you have antigen-presenting cells that are presenting into your lymph nodes. And in your lymph nodes, you have B cells and T cells. The B cells make the antibodies, right? And some antibodies just stay there temporary, or just like your IgMs, that are just acute. And then we have IgGs for next time you get an infection, right? And then when you have an active infection, you have B cells, but it can get exhausted. It's producing all the IgGs, all the IgMs you want, but then it's going to get exhausted, right? You need to tell your bone marrow to make more B cells. That's what your helper T cell does. It's also going to say, hey, if you guys see anything out there, do we still have an infection? It's going to bring things, all the boys to the yard, and it's going to cause the whole thing to proliferate, right? So it's very, very integral to the whole system. And then HIV specifically targets those helper T cells. It is an RNA that's built inside that it integrates with, sorry, it doesn't integrate, it's the capsule integrates a different word. I should probably just read my notes here. It's going to cause, what's the word it called? It fuses, sorry, it's a fusion. The reason I bring up these words is because they have medications that are fusion inhibitors and integrase inhibitors and nucleoside inhibitors that inhibit the nucleosides from being made in the nucleus, right? It also there's medications that inhibit the HIV from even attaching to your helper T cells, right? It also has medications that stop the release of HIV. So reverse transcriptase inhibitors, right? Usually when we transcribe things, it goes from DNA to RNA, but this one uses the RNA that it has, and it's encapsulated the protein that will reverse transcriptase and make its own proteins. It'll assemble itself in the cytoplasm. So it proliferates and proliferates, and the HIV viral load you can measure, right? The HIV RNA amount you can assess, and also you can assess if they have the antibodies against HIV as well, right? So also CD4 is the generic name for helper T cells. So your helper T cell count will go down, and that's called the CD4 count. So the CD4 count is low because they were destroyed, right? Usually your immune system will apoptose things that are not working, right? So it identifies, oh, you're infected. Okay, come over here, please. All right, and then you hear a loud noise, and then you no longer see the helper T cell anymore, right? So then it keeps doing that, and then now that's one reason why it goes down, but also once the virus is done with it, it doesn't have any more ATP to give, it will also destroy the helper T cell, all right? So the viral load goes down, we form antibodies acutely, but usually you don't get HIV acutely. It's going to take a second, or like 12 years, 10 to 12 years for that to proliferate and then for you to develop disease, right? Develop symptoms. But usually you don't develop symptoms of HIV, you develop symptoms of a weakened immune system, which is acquired immunodeficiency syndrome, or AIDS. All right, so yeah, so it's rare to have like a primary infection. You might like feel fatigued, you might feel malaise, just like a normal viral infection, but really it's going to take about 10 to 12 years for you to actually have a AIDS situation, right? And it's called a AIDS-defining illness. So you have something that usually attacks immunocompromised patients, right? That defines AIDS. So here we might have like a primary infection, but eventually you're going to get all these infectious diseases, which we'll talk about in the next slide. These are called opportunistic infections, or OIs. Okay? But diagnostic tests, you can assess HIV antibodies, you can assess the viral load, they can assess the CD4 count, right? CD4 count is assessing how many helper T cells you have, right? And if that's less than 200, you're really high risk to get a opportunistic infection at this point. Right? So we assess it every 3 to 6 months, and then basically they need to be on medications once we identify it, and we're assessing that it's going in the right direction, right? That it's going up, that we're getting more CD4. Like a normal CD4 is about 1,500 or 1,000-ish, right? And once you get a less than 200, then we're at high risk of being immunocompromised and being infected by something that could cause death. Yes. Yeah, so if you get exposed to HIV, you need to get started on antiretroviral therapy as soon as possible. And a lot of antiretrovirals nowadays can be curative, right? So, and once you get an opportunistic infection, it's kind of hard to bounce back, but if you catch it early, then yes, you can. Okay, so yes, so AIDS is acquired immunodeficiency. So you are immunodeficient because you don't have helper T cells, right? And it's defined as CD4 less than 200. That's your helper T cells, right? So your CD4 is less than 200. It's 150. It's 100. It's 50. And you have an AIDS-defining illness. But basically is something that is going to cause, which is only found in AIDS patients usually. These are things that affect someone who does not have white blood cells, right, to be operational. So once CD4 is less than 200, that means we don't want that to happen. So if we know someone has HIV, we see their CD4 counts going down, of course we're going to try medications, but we're going to stop those bacteria from possibly causing a infection. All right, so there's things that can be dormant. So as your CD4 even hits like 400, 500, it's starting to come down and going down this way. It can be like TB can reactivate, right? TB, like now's the time, and then it's going to get out of its little capsule and it's going to eject and cause TB, right? And then we have like hepatitis B and C. Like I mentioned, those guys they're going to be dormant and they're going to be active when you're immunocompromised. Herpes simplex virus, that causes shingles, and there's something called disseminated shingles, where it's not just causing the dermatomal rash, it goes everywhere through the bloodstream, and that can be deadly. So we want to make sure that we are vaccinating against that if we know someone has HIV. So we can vaccinate against Hep B, we can't vaccinate against Hep C, but we're going to make sure they have their vaccinations as far as our nursing considerations. I think that's on the next slide. All right. And then deadly OI. What's an OI again? That's an opportunistic infection. So we're going to prophylax. We're going to make sure they don't get these OIs by prophylaxing with medications to prevent this OI from even happening at all, right? Usually you can stop prophylaxis when you're greater than 200. But once it hits 200 or less, you're going to start medications for this patient. And the medications, and these infections are deadly. So it's important to prophylax against it. All right, they only attack patients that have AIDS usually. All right, so pneumocystis carinii fungal pneumonia. All right, so it added Girovechi recently. I'm not sure if it got married or not, but it used to be called PCP, and everybody calls it PCP pneumonia. So PC pneumonia, just like HIV virus, right? The P stands for pneumonia. Either way, PCP. If your CD4 is 200 or less, we got to start our friend Bactrim, right? Bactrim has a lot of side effects, but PCP is much more deadly. Okay, notice Bactrim is also used for preventing MAI, or Mycobacterium avium complex infection, MAI, right? So these are deadly infections that we want to prevent. And then toxoplasmosis. So we got 200, we got 100, and we got 50 basically, right? When your CD4 count is 50 or less, we're already on Bactrim probably, but you got to make sure they're on the Bactrim. And then, if it's 100 or less, we're going to start azithromycin. Azithromycin will be used for toxoplasmosis, right? That's the one you get from cat litter, right, and be pregnant. Anyways, you got life-altering OIs. All right, they get esophageal candidiasis. So it's not just like they just get these little 4 infections. On the previous slide, I have a whole bunch of infections. We have more infections here. We got all these infections that can develop with someone with AIDS. Right? They get esophageal candidiasis, so they can't swallow. Right? It's very, very painful to swallow. Usually they're going to be on a nystatin for that, right? For fungal infection. When we talk about chemotherapy, patients usually get started on that as well because the chemo is going to destroy the throat. And then recurrent bacterial pneumonias. They're a high risk for infection, just general infections. These are infections that are just waiting for the right time when they can take hold, but regular infections can cause disease, right? So that's why we want to make sure they get their pneumovax and their fluvax, so they aren't every flu season in the hospital. All right, CMV is usually comes alive when you are when there's an opportunistic situation, right? When you have a low white count, low CD4, an autoimmune situation, and that can cause you to be blind. So you can blind, you can't swallow, and then you're a high risk for cancers. Thanks. So now you have like CNS cancers are very, very common. Leukemias are common. Cervical cancers are extremely common with AIDS, right? And then cryptosporidium, you got profuse diarrhea. So not only can you swallow, you also have profuse diarrhea. And so you can see how we want to avoid all these infections, and we want to try to prophylax as best we can, and of course, vaccinate where we can as well. Yes?
Can you tolerate a live vaccine?
No, it's a good question. Next slide has it as well. Actually, the second slide after this. But when we talk about live vaccines, the herpes simplex, the HSV, the shingles vaccine is the only live one they can take. Everything else needs to be dead, right? Not weakened or attenuated, but dead, like a synthetic one. All right, so heart therapy. All right, so highly active antiretroviral therapy, heart. All right, so this is, again, you need a infectious disease doctor here. So I'm not going to make you memorize these. You already have enough meds to memorize. So these meds, you just have to recognize that these are HIV meds, and they usually end with, they have VIR in the name. They have similar suffixes, which is nice. All right, the HIV guys had the right idea when they were naming things. Okay, so they're going to be on 2 nucleoside inhibitors and 1 integrase. The integrase is what integrates itself with the DNA. The nucleosides are the ones that make up the DNA and RNA. So we give it false nucleotides to make RNA with, and also we inhibit the ability of it to integrate with the helper T cell. We also have other medications. Of course, it gets more and more pricey the more medications you add on, because these are for life. These aren't just, or actually you can discontinue them if your CD4 count is high enough and such. But you have there's things that inhibit the budding off. There's some things that inhibit the attachment of the, we call it fusion inhibitors, to inhibit the fusion of the HIV to the helper T cell, right? So that's the idea with these medications. They're always combo drugs. You're giving 2 nucleoside inhibitors and 1 integrase inhibitor at a minimum. All right, so exposure, let's go back down to, like these are examples of all the different combo drugs they can give with HIV, and the price just skyrockets. The more generic ones, or there's a lot more therapies that are more achievable nowadays because they've always been highly priced. There are more out there, but you definitely need an ID doctor to assess what's going to be feasible for the patient, what side effects they might want to avoid. So that's the idea behind HIV therapy. All right, so if you do get exposed, so someone who does not have HIV, they might need to be on antiretroviral therapy for about 6 months or so. All right, so it's the same thing. If you get exposed to HBV or HCV, you're going to bleed it and you're going to dress it, you're going to wash it, and you're going to get HIV testing. It used to be that you had to get consent from the patient before you test them for HIV. Not anymore. All right, don't need consent anymore. So it's a public health concern to eliminate HIV. Okay, and immunizations, especially if it's less than 200, we're going to immunize against the pneumovax, the pneumonia, influenza, COVID as well, right? And herpes zoster is the only one that's live. Everything else is a synthetic or dead or absolutely dead virus. Okay, there's also something called PrEP. So this is pre-exposure prophylaxis. This is if you want to have sex with someone who has HIV, or you have a partner who has HIV and you want to have sex with them, then you can both take PrEP. So it's that you're not going to get, the other person's not going to get HIV. So Truvada is the brand name for that. It's this one right here. Truvada is a combo drug. All right. So it's or if you did have sex with someone who had it, you can get PrEP therapy post-exposure as well. Okay. All right, so that way we got through all the things, and there's a few more reading at the end there, but hopefully that got you through AIDS.